Hello and welcome to the Leopoldina International Virtual Panel series on the role of data during the COVID pandemic. My name is Rebecca Winkels. I'm the Director of Communications and Strategy at Science in Dialogue here in Germany, and I'm very happy to moderate this awesome panel tonight. Before we start, I would like to address some technical measures. And the first one is that you can switch the layout of your screen to your preferred options by using a button on the upper right corner of your screen. And the second one is we would like this to be an interactive panel, and thus we are looking forward to your questions and ideas. And the way to put them forward is by using the question and answer feature on the lower part of your screen, and you can type in your questions there or your statements, and we will then bring them into the debate later on. And you can, of course, and that's for sure the easiest way to do it, address the question directly to one of the panelists so we know who you want to answer the question, though in some cases it might be obvious. So that being said, that's for the technical side. We are very much looking forward today to hosting this virtual panel on and try to explore how data can help to support the containment of the pandemic. And with me today, I'm not going to do that alone, but we have some excellent experts in the area who I would like to shortly introduce to you now. And we will then have a few opening statements by them before going into the question and answer part of this seminar. So the first person I would like to introduce and get on here to the panel with me is Simone Chousmet, who is the head of mathematical modeling of infectious diseases unit at the Institut Pasteur. Welcome, Simone. Glad to have you here, glad to have you with us. The next person I would like to introduce to you is Professor Christopher Dye, Professor of Epidemiology at the University of Oxford, who has long been working at the World Health Organization before that and is a fellow of the Royal Society. Welcome to the panel, Chris. Lovely to have you here. Our third panelist today is Professor Dr. Gerd Gigerenzer, who is the director of the Harding Center for Risk Literacy at the University of Potsdam and a director emeritus at the Max Planck Institute for Human Development. Welcome, Gerd. Lovely to have you at the panel. And last but not least, we have Professor Alessia Meligaro, who's an associate professor of demography in the Department of Social and Political Science and the director of the COVID crisis lab at the Bocconi University in Milan. Welcome to our panel. To start things off, Simon, you have been developing mathematical and statistical models to better characterize and understand and anticipate the threat posed by COVID. And that's not been easy exactly. So how did you overcome the challenges of working with COVID data that was frail and incomplete, especially during the starting days of the pandemic when we didn't really have much information as well? If you could enlighten us with your thoughts.
Yeah, sure. So I thought I would illustrate these challenges and the methods we used to overcome them with a concrete question that we had throughout the pandemic, which is how many people have been infected by the virus, which seems very simple, but actually it's quite difficult. Because, especially at the beginning where testing wasn't really great in France at the beginning, we only had data on hospitalized individuals, which really are just the tip of the iceberg. We knew that many more people were getting infected, but just they had mild symptoms, and so were not detected by surveillance. So how do you, from these small number of very sick people, get an idea of the whole size of your epidemic? So the way we tackle these problems is really by integrating different types of data, so what we call data integration. We know none of these data sets are perfect, but by looking at them together, we can try to reconstruct what we are really interested in. And so at so very early on in April, May of last year, we were both analyzing the hospital surveillance data in France, which actually was relatively good, and then also external data. So here we use data for documenting an outbreak in a cruise ship, the Diamond Princess, where all the passengers had been tested. And so from this data, we could know who was infected, and among those infected people, who got very sick or got hospitalized or died. And that's the kind of data you need to make basically the assessment for one hospitalized individual. How many infections can I expect to see in my population? And once you know that, and if you look at all these data sets together, you can start from the French data to make an assessment about the size of your wave. And so at the time in April, May, our assessment was that by the end of the first lockdown in France, we would get about 5% of the French population infected by SARS-CoV-2. And so what's really interesting is to see how this assessment changed as more data became available. And of course, to know the question to that question of many people have been infected, what you really want is serology, where you collect blood in individuals, then you see if they developed antibodies, and if so, it's likely that that they got infected. Unfortunately for us, the French modelers, it took a bit of time to get that kind of data for France. And so for a while, we started to see data from other countries, Switzerland, UK, the kind of serological data we needed for France. And what we were really interested in knowing is how consistent are these data with our first estimates for France that did not rely on serology. And it's a bit tricky because, of course, the epidemic in Switzerland or in the UK is not the same as in France, and the demographics may also vary. So here again, we did an effort to first gather as many data as possible. So mortality data, we gathered mortality data for 45 countries, so about 3 billion people, and serological surveys for as many as we could. So at the time, there were about 20, to put everything in, again, an analytical framework that could help us correct for the fact that different populations have different demographies, that the epidemics are not at the same stage at different countries. And then when we were using all this data internationally and trying to anticipate what they meant for France, we get about the same signal that of our first estimates of about 5% of the French population infected. And eventually the serological data arrived for France, the one we dreamt about for months, and it was very similar to our early estimates of about 5% of the French population infected. And then of course now our assessments, so as soon as we got this data, we recalibrated all our models on the French data we wanted from the start. And that's the one that we are using now to answer that kind of questions. But you can see that this is a process that is continuously evolving. So the initial data will actually be often very limited, and we know all the problems we have that exist with this data, but we need to work with them with the accounting for as many biases as we can, and then progressively the data gets better, and we need then to really be in a position where we can actually look whether or not they give the same signal, like the French data set versus international data set. So it's really an evolving process where progressively we reduce uncertainties as the quality of the data improves. And I will stop there. Thank you.
Thank you, Simon. We've heard a bit about the problems, and we've heard a bit about the problems of data gathering. Chris, you were part of a group that coordinated a statement that said that we are not really, or one of the main points was that we're not really fit for operating a pandemic alert system for the purposes we needed it for. And so my question to you would be, what would be the case? How would you improve that? And what is your proposal to facilitate the data access and the data sharing on international health emergencies? And how far has that not worked properly?
Yeah, thanks very much, Rebecca. The reason we did this work, of course, was because the UK hosted this year's G7 meeting, And as part of that process, the Royal Society, as the leading academy in the UK, coordinated scientific input from the seven country science academies, including information about data for pandemics and other international health emergencies. As everyone probably knows, the UK will be handing over to Germany next year, so the Leopoldina will play a central role in this. So we need to stay in close contact as we carry out that handover process. As everybody watched the news from the G7, it became pretty clear that with regard to the pandemic, there was a dominant discussion about vaccine availability worldwide. And that clearly was a very important discussion. But the G7 said a lot about data as well. They identified, for example, the need for better early warning systems, and they identified the need for an international pathogen surveillance network, among other things. And there's lots more detail in the communique that was produced by the G7. So from that process, we have the cue to do more and to do it better with data. And the question now, of course, is what actually will get done, how will we do it, and who is going to do it? And those are the questions that we need now to address. But to begin to answer that, I thought I would just run through very briefly what was in our G7 background paper produced on behalf of the 7 science academies. There were really 4 areas: principles of data operation, the operations themselves, data skills, and then the governance process. And I've written them down in that order because I think they're in ascending order of difficulty and importance. And I'll just say a word about each one. First of all, with regard to the principles of data sharing and data management, there's been a great deal of discussion about this. We have systems like FAIR, F-A-I-R, that many people know of, where FAIR is an acronym for findable, accessible, interoperable, and reusable. And when we have discussions like this, it's pretty clear that people are very ready to agree on the basic principles. The troubles arise when we start to put the principles into practice. That's when the gears start to clash. But the principles, anyway, is an important starting point, and I think we should revisit that as the platform on which we should operate. The operations part, secondly, is about software systems, hardware systems, the infrastructure for managing different types of data. And all of this is important, but I'm not going to say very much about it here. We may come back to it later in this discussion. I'll pass over it quickly here because it's not what I regard as the number one challenge. We've got lots of progress in this area. Technology is throwing up many fantastic solutions. Huge progress is being made, for example, on genomics, which are widely discussed even in the media these days. Progress is being made in handling large volumes of data through artificial intelligence and by other mechanisms. So lots and lots of progress that's going on there. There are important questions to be discussed about the kinds of data that we collect, as implied by what Simon had just said, and also about how we integrate different kinds of data. But we can come back to that perhaps later in the discussion. The third area is skills. I'll mention this very briefly because I know Gerrit in a few moments is going to say much more about this, but anyone who's worked on epidemics and infectious diseases and pandemics around the world knows that skills in data compilation and data management are highly variable. And in many low-income countries that I've worked in Africa, Asia, Latin America, Eastern Europe, and so on, even the most basic skills in data compilation and analysis don't exist. So we need to massively invest in that area. But I'll say no more about that at the moment. The fourth area that I do want to spend just a couple more minutes on is the governance question, because for me, this is the number one challenge that we face. The overarching governance framework that we operate with on epidemics and pandemics at the moment is the international health regulations, for which WHO has oversight, IHR as they're abbreviated to. And during this pandemic and in previous pandemics, it's clear that IHR has not been fit for purpose. WHO's own IHR review group a few months ago said, quote, countries that have approved the IHR, and that's most countries around the world, only applied the regulations in part. They weren't sufficiently aware of them, or they simply chose to deliberately ignore them. So IHR is not fit for purpose. So the reason, of course, is that the rules, for example, on timely sharing of data, which is just one component of IHR, are not seen to be in the best interests of certain countries at certain times. So what's the solution? Very briefly. Well, if you read the World Bank's very important World Development Report this year, they're calling for a social contract for data founded on value, trust, and equity. That's the words that they use. And there are frequent calls too for data to be treated as public goods. But if data, for example, is the new oil, data clearly has value. It's not non-exclusive, it's not non-rivalness, and it's not essentially a public good. So we need to be more pragmatic about how we reach agreements on data sharing. And the flip side of data sharing, of course, is data security, which is also important, and the two need to go hand in hand. So in my view, the way to create value, trust, and equity is not by leaning on a moral or an ideological argument. It's about being smarter and more pragmatic. It's about aligning motives and aligning incentives. And that goes for the public and the private sector. Just one very brief example. The genomic database that's been widely used, GISAID, GISAID as it's sometimes called, was first created to share influenza, and it developed into, or was built on the back of, the so-called PIP framework, pandemic influenza preparedness. And it's worth revisiting the history of how that was developed. The goodwill that now exists was built over a period of approximately 5 years, and it was only through hard negotiation that we developed this sharing of information based on trust, quality of data, timely availability of data, and utility of data. And that kind of hard negotiation, pragmatic negotiation, is what we need to build a smarter governance system now. So the bottom line of what I want to say is we need to think about principles, operations, and skills, as I've said, but what we need above all is a smarter approach to building a data governance system. Thank you.
Thank you, Chris. I'm passing on the baton, kind of, because you've already spoken about skills and about the people factor in it. I'm going to hand over to Gert in a minute, because, I mean, during the pandemic, a lot of people have come into contact with data on a very regular basis, but just being engaged with data doesn't necessarily mean that you're understanding the data. So if you could speak a bit about how we can translate complex data to our everyday understanding and how we can strengthen the literacy and data skills within the society, that would be lovely.
Yeah, this pandemic is unusual. What makes us fear are not pictures, it's numbers, incidence rates, mortality rates, R values, and so on. Yet the best numbers are of little value if people do not understand them, what they mean. And many of us are still not used to ask, what is the scientific evidence? Where do I find it? But rather, we rely on rumor, on simply what others think. And most ordinary people, including journalists and politicians, have never learned to think statistically. And not understanding evidence is an issue that matters. And I will talk about the human side, about the communication to the people. It is one of the reasons why people don't see the point of getting vaccinated. According to polls, last polls I've seen, about 20 to 25% of US Americans say they will not take the vaccine. In the British are just 15%, and I think the Germans are a little bit more enlightened. But resistance against vaccination has many reasons, such as identification with peer group, psychological reasons, but innumeracy is a key reason. So my point today is that we should prepare for the next crisis by helping the general public and also some experts to become risk literate now. We missed that the last time. We missed it after the swine flu, we missed it after the bird flu, and we missed it also after the financial crisis. So let me just start with a few facts, and then I will go on what we do in order to remedy the situation. So a few facts about collective risk illiteracy. If one wants to understand a PCR test, the result, or a quick test or an antibody test, one needs to know what sensitivity means, what specificity means, what the positive predictive value means. No. We cannot expect from the general public that very many will know that. But the point is, studies show that if we test medical personnel, like the final year medical students, I'll just give you a few numbers from the last test we did. 25% of final year medical students and lecturers and professors of medicine do not understand the term sensitivity. That means in a multiple choice, they cannot pick the right answer. 40% don't understand specificity, so it's just a term. And about 50% do not understand of medical students what a positive predictive value is. 20% of lecturers. And almost nobody can calculate Bayes rule. This is just an illustration where we are. And so we are not in a position, and we have not taught people to understand the evidence. We have developed very simple techniques so that everyone can understand what the so-called positive predictive value is. That means if you test positive, what's the chance that you actually are infected by COVID? So, and that are called natural frequencies, no probabilities, just frequencies. I'm not going into here, but you can read about that. And it's spreading. We have shown that fourth graders can reason the Bayesian way if you present the information the right thing. So there's hope for doctors, there's hope for everyone. And the Harding Center for Risk Literacy, which is now at the University of Potsdam that I direct, has on its websites all these techniques. We have them. We can do better communication. It just needs to be implemented. And also the awareness needs to be there. So the same holds for vaccination. So we have a number of problems that prevent people from understanding the benefits and harms. It's the illusion of certainty. So still large parts of the public and politicians are surprised by the news that some people who had been vaccinated twice still got infected. But 95 efficacy is not 100%. Nothing is certain in the world except death and taxes. And so let me come to an end. So what I'm doing, developing tools to help people to understand the benefits, harms of vaccines, of various vaccines. That's in the form of fact boxes, where no misleading statistics, no probabilities are used at all, just numbers. And I believe strongly that we health authorities need, the next time, be better trained in providing clear, well-formulated information to the public. And we need to move towards a risk-literate society where people are used to deal with numbers in the same way as they can deal with letters, with reading and writing. If we fail to revolutionize schools, where we still teach the mathematics of certainty and not statistical thinking, so it's algebra, trigonometry, and other things that are beautiful, useful, but not as useful as statistical thinking. We need to change that. We didn't change it now. We need to change journalist training. And at best, every politician who applies to a position should show its risk literacy. So let's be prepared for the next pandemic.
Thank you very much, Gerd. Both Chris and Gerd already mentioned politicians as a target group for communicating about data and have gone into the policy making that's needed and that it needs to be based on robust projections. But Alicia, maybe based on your experience in policy advice, how do you think that data can be harnessed to promote those responses, and what are also maybe the limits of that in policy advice and policy making?
Hi, thank you, Rebecca. I think that, I mean, we have seen in the past 15 months, I think we have gone through a sort of stress test for our health system and societies as a whole. And I mean, we have heard from our speakers here that, I mean, it's well recognized that the data has played a big role and internationally and nationally for policy making decisions. But actually, I'd like to take a step back and think about what were the actual, I mean, unpractical use of the data while the first wave, for example, of the pandemic kicked in. And in particular, linking to what Simone was saying before, at the beginning, the data was really very much scarce, very much kind of uncertain, was built over the days, over the weeks. And so there has been a period in which the data was really used in order to give us information about the infection that was coming in our societies. And this was important because if you think about, I mean, data being used to inform policy decision making, at the beginning of the story, you have to understand what you're talking about. Okay, so at the beginning there was this huge effort in all in all contexts to use the data to understand and to characterize better the infection. And we went through that process of integrating different data sources, integrating different information, building up the surveillance system and structuring better infrastructure for data collection to being able to use this in a more kind of effective way. But one experience we had in Italy at the time that I think was very important in terms of policy decision making was in the very first weeks of the first wave of the pandemic, when we started having some knowledge about the epidemiological quantities of the infection. And so, and policymakers were very uncertain about what to do and how to move, how to drive the decision, what kind of intervention to be put in place. And this insecurity at the policy decision-making level was kind of, was dragging a bit. I mean, it was not, there were guidelines, there were policies written for preparedness plans and so on, but actually the implementation of the actual policy was not straightforward. And so in different contexts and countries, and we did this in Italy as well, modelers started putting those epidemiological quantities in mathematical models to perform a projection, which is what we normally do, and we have done that in the past for several different infections. And by developing these models that were based on robust data, well, robust, relatively robust at the time, let's say, but the best possible data that was available, we were able to show what was going to happen if no intervention was put in place. And I think that in terms of policy decisions was a very effective and striking, I think, also for policymaker aspect, a very important time at the pandemic, because it actually put down on the table what was going to happen in terms of infection, in terms of bed requires in the hospitals and intensive care in order to face what was getting into our societies. And so that was kind of, it was not the unique tool, but was one of the tools that was used and that pushed the decision to move faster and to implement, at the time in Italy, we had to implement isolation and quarantines of red zone, implementation of red zone in some municipalities in the Lombardy region. And so I think data is kind of, I mean, there's a lot, I was I'm very much in agreement with what has been said about data limitation and what are the next steps that are required in order to really set up a system that is effective in generating useful data and sharing data, being compliant with the privacy aspects. But I think that's where the data is really coming into play to show what is, I mean, first of all, to characterize the emergency that we are considering, and then to show what is going to happen, to do simulation in order to show what's happening if under the different scenarios that are put in place. In terms of limitation, just briefly, the limitation have been already mentioned, but I think one of the main limitations over the past year has been the fact that it's difficult to get real-time data and good data, robust data. And so we have to rely on data that is it's kind of building up over time. And so all model prediction and the analysis that are being made have to be adjusted. And this make policy decision-making, again, that has to be adjusted over time. So even thinking about the public and the compliant to what to the measures that have been put in place, the public have been really much kind of against this change in policy, change in the intervention. But this is actually part of the story, because when we have an emergency situation and we have to adapt our decision real time, given the knowledge that is being built. So I think this is I mean, there's a lot to be said in terms of how we can use data for policy decision making, but I think this year has been a kind of laboratory experiment, unfortunately, on our lives, but we have learned a lot. And I think we have created the bridges that are necessary, even between different disciplines, in order to have people interacting and supporting decision making in a more effective way.
Thank you very much. Before we're going to go into the questions of the audience, I would like to give you the opportunity as a panel to comment on anything the others have said. Do you want to add something to one of the statements? Is there anything you maybe don't agree with? I heard a lot of agreement and a lot of yes, and I saw some nods there, but is there anything you would like to add that is important from your view that hasn't been mentioned yet? Yeah, let's start with Gerd and then have Chris afterwards.
Chris, you mentioned that data skills are highly variable. Now we know since decades how important data is, long before Corona. What do you think are the factors that prevent people from becoming data literate? And what can we do?
Yeah, it's a great question, Gerrit. If we look around us in say European countries, we can have the kind of conversation that you elaborated on yourself with regard to data skills. But in many countries I've worked in around the world, there isn't even the most basic training at high school level, let's say, never mind mathematical modeling, which we're commonly talking about, or sophisticated analysis of clinical trials. That's where the conversation has been in Western Europe. But I'm really thinking about the most basic skills in gathering data, in understanding the meaning of data, in laying out figures, say, on a spreadsheet and making basic calculations, such as the use of numbers versus rates per head of population in epidemiology, dividing data up among males and females, among different occupational groups, and so on. These skills don't exist in many countries because there hasn't been training at even the most basic level. So I think we can talk about the kinds of problems that you've been speaking about, Gerrit, of course, and the courses that you've been developing are going to be fantastically useful, I think. But I will also suggest adding to your own thinking by prefacing that with some very basic data skills. And I think those basic skills are going to be needed to prepare us for the next pandemic, as well as the more advanced ones you've been talking about too.
Yeah, thank you very much. And you wanted to add something yourself as well?
Well, just a question possibly to Alessio, but to anybody else as well. Observing the interrelationship between science and political decision-making in the UK in particular. This slogan was adopted by politicians who said, well, we're following the science. And the science was actually science of quite a limited kind. It was, in the first instance, it was heavily oriented around mathematical modeling. It was then broadened out a little bit later on. But what was not made clear to the public, I think, is that science is an input to a much broader ranging decision-making process, and that there are some things that scientists can say that politicians can use, but there are political decisions that need to be made as well. So you don't make policy, in other words, simply by following the science. There's more to it than that. And that slogan, therefore, I think in the UK context has perhaps been useful shorthand for some people, but also potentially misleading as well. And I'd like to hear what the other panel members think about that.
Shall I start?
Yes.
Yeah. Thank you, Chris. This is a really great question, actually, and difficult to answer. I think in Italy we had a similar experience, in the sense that quite soon political decisions were kind of, let's say, advertised, saying that they were following scientific advice, they were following scientific reasoning, and so on. In reality, at least in my experience, is that, it's true that the kind of the community, scientific community of epidemiologists, infectious disease epidemiologists and modeler have been kind of intensively involved from the very start of the pandemic. It was an health emergency, and so we were supposed to kind of be on the ground and support in whatever ways we could. But actually, I think after a few months, when the kind of the health emergency was, I'm not saying under control, but at least was well established and known, I think there were other dimensions of this crisis that were touching on other kind of scientific communities. And so I think it was in terms of policy decision making and being supported by these other communities, I think this was, this didn't happen and didn't kind of occur in the way we were hoping, in the sense that policy decision making is going very fast. It has a pace that is very difficult to follow with the scientific reasoning. And so quite often I've seen decision being made and then a committee being asked to kind of support that specific decision with some kind of evidence. So it was unfortunately the other way around. So I think we still have a long way forward to kind of develop and better kind of establish the connection between scientific communities, and not only the epidemiology, but also the other scientific communities, and the policy making that is supported a little bit more by real understanding of the different aspects of the emergency. At the time, I think it has been used, sometimes also throwing the responsibilities to scientists for the decisions that were made without really having kind of heard effectively what the science was saying. So I think there's a lot to do more in that direction.
Yeah, thank you, Les. Yes, Simon, you wanted to add something to that?
It's interesting comparing different countries. So in France also, we had the very same process where initially it was all about, we are just following the science. And then I think everybody realized that wasn't like necessarily a good option. That is, especially when you have decisions that are as difficult as having a choice between, an exploding epidemic or very difficult decisions for some economic actors. Of course, it's not the scientists who should decide between the economy, the health, society, and it's the policy makers who need to do that. We live in a democracy, and it's they are the ones who make the decisions. And as scientists, we we are supposed to help outline the options and the implications of each of the options, but not to make the decisions. And at one point in France, there was a clarification that the policymakers actually realized that just following other people was not necessarily politically very interesting for them, and that they needed to take back leadership, which is what they needed to do, and actually, which is also what we wanted, because it was never the position, the role, and our desire to be those making all the decisions in France. We are not running the country.
Gerd, maybe adding a German perspective to that, where we had a chancellor who is a scientist and who's been praised as a scientist during the pandemic. What is your view on this issue?
I'm always happy to have a chancellor who is a scientist, and I think we had good experience with this a long time. I have a remark on follow the science. So my first reaction is always, if a politician says follow the science, wonderful, finally, good. But a politician in the pandemic can not really follow the science, because the science, if the science is virology or epidemiology, there are many other aspects. And a politician has to, and we expect from a politician, to take responsibility and try to find a kind of integration of all these views. And also, there will not be one single answer, but stand up and say, that's the decision to the best of my knowledge, and I'll stand up for that. So the phrase, follow the science, sometimes actually means defensive decision-making. So I push over the responsibility to the science, whoever that is. And I have a question to the panelists. So one case recently that looks like defensive decision-making, so you protect yourself rather than do the best, is the decision by more than 20 countries to stop the Astrazeneca vaccination for a week or so and then resume it again. And I wanted to know from the others how in your countries that was being seen. So in Germany, the intention probably has been, besides being defensive, that we prove that we are in charge, that we check everything, and we want to increase the trust in the vaccine and act against the skeptics. The result was the opposite. The vaccination doses, they were not touched, and people lost the trust. So the same happened in the US with Johnson and Johnson. So why do politicians make this type of decisions that wasn't even recommended, as far as I know, by the EMA, but just made it and followed the other countries and basically caused a delay of vaccination?
Simon, do you want to start us off with that? What was the French perspective on it?
I mean, on the AstraZeneca thing, I think there's the additional dimension actually of the fact that it's international crisis. Here, I think France would have wished to have something that was more coordinated between European countries. And I think that there was no, I suspect no real desire to go into that direction, but if you have already 5 other countries that do it, it's on a maybe purely political perspective, but also public. It's very difficult not to do it if you know that then you will be attacked for being sloppy on vaccines.
Yeah, follow the others.
Chris, what do you think? Was that right?
Sorry.
Yeah, this is not particularly a UK perspective. But I think there's an aspect of this, and what I'm saying is unproven, but I think there's an aspect of this about responsibility and accountability in decision-making as well. No politician wants to make a decision that leads to the death of somebody through a medical intervention, no matter how uncommon that is. And that was potentially what we were faced with the Astrazeneca vaccine and the complications around various kinds of thrombosis. The responsibility for that, I think, is seen to be greater than the responsibility for not taking a decision, allowing people to be exposed, and then allowing deaths from natural infections, in other words, from COVID infections. The responsibility is different for that. And I suspect that that is part of the process that politicians took in decision-making, as well as the other things that Gerd said in the first instance, and then Simon about countries following each other in this regard. And I think that warrants looking into a little bit more. I think the idea essentially clusters around the age-old idea in medicine, first do no harm.
Thank you. But do you think it would have helped if the data was better understood before that? So do you think it would have actually helped if politicians knew the risk assessment a bit better and knew what the actual data on that meant? Maybe Chris and then Gerd.
From the UK perspective, the argument did develop into more rounded form, I think. The point about responsibility doesn't go away in decision making, but what very quickly happened in the UK was that statisticians pointed out the risks, costs, and benefits of taking a vaccine versus not taking a vaccine for different age groups and for men and women in the population. And that was very widely debated publicly, very clearly presented from a statistical point of view, and I think very widely understood. And as a consequence of that, I think the debate moved on. There has been another related issue with regard to AstraZeneca, of course, in the sense that there is a feeling among the public and politicians that it is not as effective a vaccine as the mRNA vaccines, the Pfizer vaccine and Moderna vaccine. And there's a continuing debate, therefore, about how AstraZeneca will be used for that reason as well, besides the issue around thrombosis.
Mm-hmm. Gerd, do you think that was debated as well in Germany, with me thinking it wasn't really as...
Yes, we did we prepared some facts for one of the RD for the first German TV. The Harding Center did that. And also, I think there's also a positive case here, namely, as Chris said, politicians are hesitant to do something that might cause death. But at the same time, by people who wait or by delaying vaccination and also causing many later to be not to accept AstraZeneca at all. The Winton Center for Evidence and Risk Communication in Cambridge, which is our sister center of the Harding Center in Potsdam, sponsored by the same person, David Harding, and also the EMA provided infographics that help to see. So what is, if you now wait for months, depending on what the incidence rate is and how old you are, what's the risk that you end up in an intensive care unit while you're getting infected while waiting and fight for your life? And for almost all situations, that risk is much higher than the risk of getting a severe thrombosis after AstraZeneca. So here we have also a good case where the information was spread and in a way that people can understand. But again, we also need more people in the UK, in Germany, in every country who are waiting for this information rather than going by rumor in social media and elsewhere.
Yeah, thank you. We have a question from our audience that is probably Simon can answer that one. And we've talked about the data we have and how we can work around that and what we can do with it. But with COVID, we had a lot of problems with actually working around data that we didn't have, and we didn't really have the density of data in the beginning. So how can we deal with that? And also, what does make a good data set that we were apparently lacking, especially in the beginnings?
I mean, I think I gave an example of how we can deal with that. The big difficulty is that initially there are problems with all the data sets. And I mean, if you look at I think in that pandemic, actually, we were not that wrong, right? Because the first assessment very quickly pointed out to a case fatality ratio close to what it really was and a reproduction number close to the correct one. If you go back, 10 years earlier, when that was the flu pandemic of 2009, the earliest assessments of that pandemic were actually relatively for the case fatality, the case fatality ratio, we estimated that it might be around 1% or 0.5%, so close to COVID, when actually, like 6 months later, the estimates were at 2 deaths per 10,000. So we had it wrong, like by 1 or 2 orders of magnitude. So actually, so the data is poor. The good news compared to 20 years ago, I think, is that first we can. It takes maybe it's faster to develop testing and all that to start building good data sets. But then we also have developed, like the modeling community and the epidemiologists, a lot of methods to identify like what doesn't seem right in the data and start build estimates that are more realistic. And just to give you an example of that, the very first days of that pandemic, China was reporting, I think that was about 40 local cases, and but there was already 6 cases outside China. And so Imperial College did an assessment of, if you already have 6 cases outside China, it must mean that you have at least 2,000 infections in China. And so it completely changed the scale and the interpretation of the data. So, and there are a lot of that kind of assessments where you can look at inconsistencies in the data and develop methods to build what might be a more realistic picture, but you can also get it wrong, like we did in 2009.
Yeah, thank you very much. Chris, you wanted to add something to that, I think?
Yes, just briefly, while we're on the subject of data and data quality, 2 things, if I may. No data are ever perfect. I think in the public perception, perhaps there's a call for the best possible data. That's fine. But I think the question we're commonly asking is, how good does the information need to be in order to make a decision with it confidently? And that's not necessarily, that decision doesn't necessarily require very, very accurate, very precise, or very detailed data. The question is always, I think, what are we doing with this information, and how easily can we make decisions from it, even with imperfect data? So that's the first thing. The second, with regard to the kinds of data that are available, the COVID epidemic has exposed many data deficiencies in health more generally, and no less, I would say, than the deficiencies in civil registration and vital statistics systems around the world. The number of people dying, for example, with COVID or from conditions associated with COVID has been difficult to assess in many countries. We've been, as a health community, trying for decades and decades to try to improve civil registration and vital statistics systems. And I, for one, hope that the COVID epidemic will expose where we need to go, and where we need to go rather quickly in building these systems. These will be important for preventing the next pandemic, but they're important for health in general.
Yeah. I would also, there's another audience question that is concerned with how we can create trust in data and how we can actually trust data that is constantly evolving and incomplete to an extent. I think Simon already said that it's not actually the predictions are quite good and we can make a lot out of this incomplete data. But I think in communicating that issue, Gert, maybe you want to address that because it's a bit about trusting in the data we have. How do you think can we make it understood to people that they should actually trust, or to what extent they can trust data that is incomplete?
Yeah. So one first step is to everyone to be clear that nothing is certain. So nothing is perfect. And that's one of the causes of mistrust. So when people learn that, for instance, the example I had before, that someone is vaccinated twice and still gets infected, that can happen. It's not a way to now to mistrust the vaccination. So that's a very important condition first. And then we are about risk. Then we have to get risk literate and see which of the risk is larger and not. And in general, I think, and also we have at the Max Planck Institute for Human Development done a study, namely asking people in Germany, so whether they would rather have assertions of certainty or rather being the uncertainty being communicated, and the far majority trusts more in people who communicate uncertainty. And that's maybe a political strategy. So one very simple heuristic would be, so a politician should do the following. First, what do we know now? What don't we know? Second, what are we going to do that we know more? And third, what can you do meanwhile? So just make it clear that's evolving. There's nothing certain, but we all have to live and act rationally under uncertainty.
Going in the same direction, thank you for that. And I think that's one of the major challenges as well. But so if we already in Germany especially, and I think worldwide, we had the claim very often coming up that because something changed, that science was wrong. Chris, maybe you can say something about how can we change that narrative from just because something evolves and the situation adjusts, how can we communicate to people that that doesn't mean that science was wrong in the first place?
Yeah, it's an important question. The dilemma in the science community, of course, is that debate about the reliability of results is the way business is done on every day. We're always challenging what each of us says in the way in which we respond to others' work. And we make progress by identifying what's wrong as well as what's right. The difficulty, I think, as Gert has alluded to, is to have that debate publicly. I think the only way that we can really do it, actually, as he has suggested, is not to try to keep the scientific debate in a box, but rather be as open as possible as we can about what we know with regard to information, what we don't know, and to emphasize, as I think is increasingly being done in this epidemic, that one of the slogans that's being used in the UK at the moment is that we focus on data, not dates, for example. In other words, we're going to make a series of decisions. We have a roadmap, for example, for reopening the country, for relieving lockdown. But this is what we plan to do. But if the data tell us that our current thinking is mistaken, we will change our decision. Now, if the information is presented like that, then I think people do understand. Their problem, I think, is not in not accepting that. It's that people are then asking, okay, that's fair enough. The information is not precisely reliable, but I have a business to run. So what do I do under these circumstances? And the answer to that question will be different for different people, but people will be much better prepared to accept that level of uncertainty if it's presented to them honestly and openly. I think we've actually made progress during this pandemic in having that discussion more, that scientific discussion more openly.
Yeah, I think that's certainly true. We've read a lot more about it in general news as well. But Simon, you wanted to add something to that?
Yeah, I mean, that's a problem we've been confronted with. I think one of the challenges is also about what these assessments mean and how people should interpret them. That is, often people have seen them as like predictions of what will happen, when actually there are scenarios showing this is what might happen if you do, this set of interventions, or if you do that set of interventions. So scenario A, B, and C, for example. And then sometimes people, if they see that the scenario A that we presented did not happen, and they will be, yes, but so the model was wrong, when actually just the interventions that were implemented had nothing to do with the ones in the given scenario. And so that has been like, we have like had to do a lot of work to try to really explain what these models, how they were meant to be interpreted. And you need to read the assumptions, because like if the assumptions do not realize, of course, then it's not going to happen. But has taken a lot of communication around it, and I think it's still a challenge. And I also think because I worked like in the UK for like many years before coming back to France, and I also think there's some countries are the interface, policymakers working with scientists is something that has been more common in some European countries than in others, and which means that, like for us in France, there's some catch up to do, I think.
Alessia, yeah.
Yeah, just another dimension that I think comes into the game when we think about building trust in our citizens. It's the media and the communication that the media have, communication strategies that have been adopted by different media channels. And this, I think, has played quite a crucial role, at least in Italy, in the sense that the way the scientific evidence was brought to the houses of people was kind of very much influencing the individual's attitude and the trust and the level of trust that they were developing and their compliance to the measures that were put in place. So there's there are different dimensions in the decision-making process, and we have the scientific dimension, we have a policymaker dimension, and then we have this to feed back into the communities. And I think that that channels, that link has to be a little bit more thought through, because at least we had several situations. It went on for the entire last year, in which the communication was worrying, was providing anxious attitudes in the citizens. The science was brought in the newspaper in a very crude way, without any kind of explanation nor transparency about all the stuff that we have discussed here. So the uncertainty and the uncertainty of the data, the fact that there were data limitation, the fact that there was some uncertainties around the projections and so on. And so I think this created a lot of confusion, and it created a lot of mistrust also with respect to the vaccine and the Astrazeneca. I hope this year has been useful also in terms of making, or at least realizing, that the communication is a very critical part in the system during an emergency.
Yeah, thank you. Chris, you wanted to add something to that point?
Yeah, just briefly to add, and it builds on what Gerb was saying earlier on. I think that COVID has made clear that that there is a need for the legitimate science of investigating what people do and don't understand in a pandemic, and why they do believe or do not believe certain things. This is, I think this is a fairly young literature, but some of the most interesting studies, for example, around trust with respect to vaccination have pointed out that there is no such thing as a single anti-vaxxer type. There are many reasons why people don't trust vaccines. And the way to improve levels of vaccination is to study systematically, objectively, honestly, why people refuse vaccines or why people don't believe vaccine data. And I think that will be the way forward. And I suspect that this pandemic will stimulate that area of social scientific research.
Yeah, I certainly think we are seeing those debates. But Gerd, you wanted to add something maybe, I think.
Yeah, I hope that Chris is right. And I'll just point out one of the reasons that we know why people don't trust in something. And it's again a cognitive reason, so about knowledge. So many of the emotions are basically built on misunderstanding. So the distinction is between a situation of uncertainty, as in COVID-19, as in many situations, and one where, which in decision theory is called risk, where everything can be calculated. In a situation of risk, you can make 5-year plans and plan ahead. And it's not a good idea typically if you change course. Under uncertainty, you cannot make 5-year plans. And a politician who changes course based on the best information should be applauded, not mistrusted, because that's what needs to be done. And if one understands that, that difference, so ask yourself, what is this situation? And if it's about uncertainty, you cannot expect to have a plan for 5 years. You can expect to have many plans. But trust here, that's not a matter of distrust. Trust is, there are two kinds of trust. One is in motivation, one in competence. And there are politicians whom we trust in motivation, but not in competence, and vice versa. That's also an issue that matters. And I hope that this study of trust of people in politicians and vice versa will flourish in the future.
Yeah, I think that's it's a very good thought, I think, there. And I think we need to work on that collectively, kind of as a society almost, and not just as individual scientists.
And it's also the other way. Many politicians don't trust the people and use the techniques like nudging to steer the people in certain direction. That's, in my view, not the future of democracy.
Before we're going into the outlook of what's happening as a conclusion to this panel, I would like to ask one more question from the audience, which is there any particular piece of data that has particularly maybe surprised you in the context of COVID? So is there anything you came across where you thought, like, that's counterintuitive, that's not what we thought would happen? Is there anything that comes to mind for any of you? Simon?
I mean, I think there have been a lot of things that, like we have been trying to predict what will happen like next coming weeks, like for more than a year, and so we had a lot of things that happened and that were a bit unexpected. Like for example, we had some curfews in France at different times that actually happened to have quite a strong impact on the dynamics of the epidemic, bigger than what we had anticipated. And then, like, I think good news on the positives of that pandemic is that really, it gave us access to new types of data on human mobility, for example, with like initiatives from a lot of the big tech companies that have been really helpful to understand like behaviors and how these behaviors impacted like the disease spread. So for me, that's really a positive. Like we had like in terms of access to that, we have built new surveillance systems that are more performant than anything we had before in France, open open data and really new types of data that have made the science more interesting for us.
Yeah, Chris, any surprises to you?
Well, two surprises very briefly. One is that we now have a very widespread public discussion about concepts like the basic case reproduction number, which were arcane statistics before this pandemic, but now they're discussed on the BBC News each evening. So that's one surprise. But the bigger point is perhaps about this coronavirus. You know, prior to the emergence of this one, we had a number of very benign, principally very benign coronaviruses, which cause common colds in the wintertime in temperate environments. And at the other extreme, we have two very serious coronaviruses that cause MERS and then Middle East Respiratory Syndrome and SARS-1, if you like, which emerged in 2002, 2003. Both of those are very pathogenic, but not very transmissible among people. What we've got now is a coronavirus in the middle of the spectrum that's both relatively transmissible. It's not highly pathogenic, but it's quite pathogenic. And it's that virus, that kind of virus in the middle of the spectrum that has really been very, very damaging. It's neither one nor the other. It's something in the middle. And that is really proved to be very dangerous. And that's a big warning about what might happen next.
Yeah. Gerd, do you want to add a surprise? What surprised you most?
I was most surprised how fast effective vaccines were developed. That was a real surprise for me. I'm not a virologist, but I'm in the Science Council of the European Research Council, the ERC, which funds basic research, and a testimony to basic research. It has funded BioNTech, who were looking for cancer, but then could use what they developed for a quite different problem they hadn't thought before. So it's also a testimony, I think, to the importance of basic research and the serendipity of much of how science is going. And you just cannot really plan it, because then there would be no innovation.
Yeah, that's very true. I think as a virologist, even they were surprised by how fast the vaccines were developed, really. Because we're coming to the end, I would like to go out with one thought from each of you on, because we've talked a lot about trust in science, and we've talked about trust in data and data literacy, and how we can get better data together. And I would like each of you to tell me one thing that you think that will have changed and maybe improved by, hopefully, the next time we're not running into a pandemic, but can actually prevent it. But just one out view of what is going to change and happen in the data science scenery that can help us prevent things like this in the future. Alessia, maybe you want to start?
Yeah. So I think we have learned so many things in the past 15 months that it's really, I mean, I would have a list of aspects that I'm positive that will be different, hopefully, if we have another challenge like this in the future. But one aspect in particular, I think it's related to the opportunity of sharing the knowledge between different communities, different scientists, different groups. So the gathering of the data, it's not something that, I mean, we have seen that it's not enough that the single country is collecting data and analyzing the data in their own. It's very important that we share the information, we share the data between groups that are working in the specific field. So I'm not saying that we're gonna kind of throw the data to the jungle and see what happens, but sharing the data between experts and the knowledge that is being built on top of that. I think this accelerates a lot the process of understanding. And so if we do understand, then we're going to be in a better position to develop new tools to address the challenge. So I hope we will, the take-home message from this 15 months is going to be something like this.
Simon, what's your take-home message? And
I think for me, like in the French context, I'd say that an acceleration of how policymakers work with scientists and how to make this connection work better. So, you know, with shall we go with an option like in the UK where you have a chief scientific advisor? How do you make sure that you, in the different ministries, you have not just tech, not just you know, civil servants, but also like civil servants with a strong scientific training. And so how to make that work in a way where it's not like the scientists write a report that ends up on a desk where they have difficulties understanding what's happening. And so that, I think, pandemic has kind of helped make things move forward. And I think we will really see an acceleration of how we improve that further.
Thank you. Chris, what's your idea for the next coming up?
Yeah, I want to come back to the point that I emphasized at the beginning. I think we need a smarter, more pragmatic system for the governance of international data. That's my number one priority. We've seen that the international health regulations, despite the fact that IHR is a body of international law, is not fit for purpose. That's been said many, many times. That includes the aspects of IHR related to data governance. We need a more pragmatic system, one that's been developed like GIS aid, which reflects motives, incentives. In other words, we need to do the deal on data sharing so that data have benefits for everybody and everybody understands what they will get out of it. If we align incentives, then we'll come up with a smarter system. And I think that's the area we need to work on.
All right. Thank you, Gerd. It's your turn.
My vision is that we learn from the corona epidemic and we learn what I would call risk literacy. So that's the joy to think about risks, not the fear. It's all risk, our life, you know. It's only, there will be only no risk when we are dead. And that's so a culture to change. So a culture where in the families, we discuss not just soccer, but we discuss issues that what is dangerous, what could happen to us in the next 10 years. A culture in schools where risk literacy is an active part. So how health literacy, for instance, and a culture at the universities and at the political level. So that's my vision. So, so that people take their own lives in their own hands and in an informed way and take the remote control of their behavior out of the hands of others.
Thank you very much. I think that those are brilliant closing words to our panel session, because we've all learned a lot, I'm certain, about data today and about the different perspectives from different countries and how data was used during COVID and what went wrong and what went right as well. I think I really like that you all had a positive view now and are leaving us with positive thoughts, right, rather than negativity, which is great, I think. And so I thank you very much for joining us today. Thank you all for listening. And it was a very lovely discussion. I think we all learned a lot, and I hope you have a very good day. And thank you all for being here.
Thank you so much. Bye.
Thank you very much. Thank you.
Thank you.